Good afternoon, everybody. We're here for what is now our 16th Digital Dispatches. Thanks very much for taking the time out of a Friday afternoon to join us. This afternoon, we are coming back to a hot topic, encompass. It seems to be something that's generating a lot of conversation, so we'll continue to facilitate these sessions throughout the year. We're now officially into the countdown for Southeastern Trust 1 year and counting, due to go live September, October 2023. Belfast following hot in the heels 6 months later, and then Northern Trust in September 24, and then Southern and Western kicking off April, May 25. So lots of work to be done. And lots of interest being generated around HSC and beyond. So today we have chosen to home in on one particular topic that will demonstrate how the way we deliver and work in the health and care system is going to change as part of this programme being rolled out across the whole of HSC. If you have questions, I'd appreciate it if you put them in chat or raise your virtual hand, and then the panel that are going to be chatting with us today will pick those up. Today we've chosen to pick on a topic that is well known to lots of people, either because you have the condition yourself, or you know people who are managing it, or you maybe support somebody who has diabetes. And we have three key people on our panel today that have different perspectives on the condition and can talk about how the Encompass programme will change how your diabetes treatment care pathway may change. So Sharon McCartney, is a diabetes specialist nurse, and she's based in Gelvin Hospital. And she is coming at this from a very unique perspective, in that she also has type 1 diabetes and has a daughter who also has type 1 diabetes. We have Peter Jackson, who's an AHP Encompass lead and is based in the Belfast Trust. And then we have Neil Black, who is our Chief Clinical Information Officer in the Western Trust and is also our consultant physician and clinical lead in endocrinology and diabetes. So I'm going to hand over to them just to give us their insights so far, and we'll take your questions as we go through the session. Okay, Peter, can I hand over to you?
Yeah, happy to do that. So welcome everyone. It's nice to see so many faces on the call today. So we're going to start by just having a brief overview from a patient's perspective for someone living with diabetes. So I'm going to hand over to Sharon just to get started, who will talk about some of what the difficulties are around systems and living with diabetes and the lack of coordination across the systems. And then myself and Neil will come in and talk about some of the opportunities that Encompass will offer around that.
Hi, I'm Sharon. So I suppose, as you've heard, I'm a DSN patient with type 1 diabetes and a mum of someone with type 1 diabetes, but coming at it from a patient perspective, and the sort of challenges that we would face as technology is ever changing. It's coming at us thick and fast. So it's trying to keep up with that, trying to get all the information in one place, knowing where to go and signposting it right, just to empower us as patients to live with this long-term condition. And difference between adult and pediatric is a big thing as well. Adult care, I kind of know in and out. And then from a pediatric point of view, it's so different from stepping over. So I'm hoping that Encompass will be able to support that going forward as well. Just having the educational tools and being able to manage that as well would be good.
And I think just in terms of one of the challenges that we definitely do see for people living with diabetes is about this coordination around appointments and that ability to connect with people working in health and social care. And definitely one of the really exciting elements of of the Encompass project is the patient portal, or the My Care record, that Encompass will bring with it. And I know that across diabetes services, the patient portal was trialed and has been implemented. But when we go live, there'll be much more functionality around that. It'll be used a lot wider. And I think for me personally, that's one of the really exciting elements of Encompass. And I definitely think, and diabetes is a great example of this, a condition which people have, this throughout their life, that they'll have to manage, that there's such a big role for people to try and manage this as well as possible because it improves their outcomes. And having a mechanism that there can be much more connectivity, and really to allow people to be partners in care with their healthcare provider, I think is really, really important. So a few of the things that the My Care record can deliver on, firstly, is that coordination element. So people living with diabetes often will have multiple different appointments that they have to attend and manage across different professions, sometimes in different trust areas, and definitely in different locations. And that can be really hard to coordinate, just given the vast number of them. And for AHPs, we know that obviously our podiatry colleagues would routinely see people living with diabetes. Our dietetic colleagues would routinely see people living with diabetes. And those patients would then have to see our medical colleagues, our nursing colleagues, and a number of other healthcare professionals. So having the ability for people to log on to My Care record, either via the app or online, means that they can manage all of their appointments online. It means that they can coordinate their diaries. They can see what appointments are coming up. And I think that's it's quite a simple process, but it's a vital one because it's so hard to coordinate all of the appointments that are happening across the system. So My Care record, that's one of the areas that can deliver on. The second is, and I know for AHPs, and I'm sure all of our colleagues are the same in this, one of the things that we've traditionally wanted to do is to provide as much information for patients as possible. And for anyone living with a long-term condition, it's really important that they have the information that they need when they need it. And traditionally, AHPs have given lots of information via an information leaflet and a printed leaflet. And I know personally, when someone gives me a leaflet, it's quite hard to find a week later, never mind 6 months or a year later. Whereas actually, this will all be kept in one area on My Care record, and it'll be a trusted resource, a trusted library of resources. It really limits people having to go out and try and find all of the information, because we can manage that as healthcare professionals on one side. We can make sure it's the information that people need, and they can access it at a point in time which suits them best and when they need it the most. So having that trusted and validated library of resources is the other key component. And that library of resources and the appointments can be accessed by the patient, but also accessed by the parent of a child who's living with diabetes. And just to help to coordinate all of their care, I think is really important. And I mentioned before about having partners and having really this partnership in care. And it is about improving that communication, I think, between people who are using services and ourselves who are delivering services, I think is really important. But also the other elements that My Care record can give, which are the test results, which I think is vitally important when we're looking at people self-managing their condition, where they can access the test results that they need to and all of the information they need. But for me, one of the big wins for this is when someone goes and sees a healthcare professional, sometimes they're given so much information and they come away not quite knowing what the consultation has been part of and fully consisted of. But summaries of consultations can be added to My Care record. So essentially, someone can leave the hospital and leave their consultation, and they can access a summary of what information was provided at that consultation. So they can go away and talk to it with family or friends, or they can just go away and be able to read it and understand their condition that bit better. So it really is about empowering people, engaging them in the management of their care and helping to coordinate their care much better. And Neil, I'll maybe pass over to you if for the My Care record, just to add some other perceptions from a clinician's point.
Yeah, we've tried really hard in Northern Ireland over the last decade to join up separate silos of information. Your general practice information is separate. If you're working on or living in a trust boundary, or you're referred from one area to another, the information that one trust holds about you won't necessarily be passed across. It's certainly not easily or reliably or even securely. And also, even within individual trusts and individual hospitals, the individual living with a condition, whether that's acute or chronic, may find that different professions hold different information about each other. And they're not necessarily easy to access. And to date, leading up to the encompass, we've learned massive lessons from implementing the Northern Ireland Electronic Care Record. Now, it has had huge limitations with respect to what it can share, but it's completely revolutionized secondary care, and we feel it's helped make care safer. We're also learning a few lessons with respect to, well, how can the care record help my care record? And the current patient portal is proving useful because people can now start to see their appointments. And I think what's been happening to date is we've been waking up to how safety can be improved and quality of care can be improved, but we're only just realizing how much value there can be whenever you actually share that information with the person living the condition. And people will living with diabetes can live it for a very long time. And one of the real classic stories is, jumping on the bus to get to the hospital clinic appointment. You haven't seen this fella for, several months or whatever, and you don't know what's going to happen. And you fill in your paper diary with whatever information that's available to you on your glucose values. And you arrive and you bring that in with you, terrified about what result you're going to be told from the laboratory. And that result was a secret thing. It's held back from you and hasn't been shared until that moment where you're unprepared and it's thrown at you. Now, granted, the world has changed since then, and we're sharing glucose data through third-party apps, and we're back and forward electronically, but it's very, very clunky, and all this information isn't held together in one place so that you can gain a shared understanding, the professionals and the person living with the condition. One classic tagline from the diabetes online community is that people, I'll exempt Sharon from this comment, but you have a person living with a long-term condition and you have a specialist. The specialist is not the expert until you add the person living with the condition to them, and only then together do they become the expert. And to really do that, both people need to hold the same amount of information, and there's a vast quantity of it. So for either to understand it all, they need the other. So for me, the sharing of that information is crucial to gaining a proper understanding, both the person living with the condition and the clinician. And Sharon said a key word there, which was empowerment. How can you possibly be empowered to look after yourself, or motivated even, if you don't have your own information? And we shouldn't be afraid of this. Clinicians can be afraid, oh my goodness, well, if they can read my letter, goodness knows what questions will come next. Well, actually, questions can reveal things about the person, about what they're afraid of, what the priorities are, what's important to them. And if you don't understand that about a person that you're helping to look after, you can't really focus on what they need and what they feel they need. And it's in diabetes, the big example is, a person comes up to the clinic and you spend all your time talking about their glucose. And how refreshing it is sometimes to spend your time never having talked about glucose in the whole consultation, because at that moment, that's what that person feels is important to them. The care record as well, it needs to follow the person right the way through their life, from each of the different stages of whenever they're a child and dependent to they reach their own legal majority and they can own their own record and their own information. And second of all, it needs to follow that person right the way through the country. So what is envisaged and what has been built is immense. The amount of potential for releasing what sometimes we've called the third estate, the person's own ability to understand themselves and their own condition, is totally immense. And have been trying to realize this in diabetes care for really a long time. And we're struggling, but with little bits of this and little bits of that. We've even turned around, our letters aren't addressed to general practitioners anymore. All our letters are addressed to the person living with diabetes, and they're copied to the GP. That means a change in language and a change in mindset. But to be honest, the feeling for a healthcare professional in doing that is quite incredible, to realize I'm talking to you and I'm feeding that information directly back to you. So you can tell me, is this a true understanding? Have you captured something important about me that I can agree with? That sharing of information is empowering for the clinician and the person living with diabetes. I wonder, Sharon, could you tell us something about how you feel about having your own information? And I suppose that goes for you, but also for you as a mother.
Sorry, hello. Yeah, I didn't mean to unmute myself. Sorry. As a person living with diabetes, like, I'm all about independence and managing this condition with obviously support as I need it. So getting to see my record on my portal and seeing my HbA1c, and as you had mentioned about coming into clinic and getting all that information, sometimes it kind of goes in, but then it doesn't stay. So it's good that you can go back and recap on the numbers and recap on your ratios and recap on anything that you need to go forward and do. And the same goes for Molly. And that journey that you were saying, from going to pediatric to adult, I just think having that record all in one place will be essential for my daughter's independence when she gets to that age where she's going to be taking this on, because then she'll know what way to follow it and know what way to go through things. So having that information is just, it's helping me go through my life with diabetes. Like years ago, like I'm 30 years diagnosed now, and it wasn't available 20 years ago. Like it was all what the doctor told you. Whereas getting that empowerment and have a say in my own control is excellent.
And Sharon, I also think it'd be really useful to get your perception on this as well. The challenge that we have currently, which is where we have so many different IT systems in place, so many different mechanisms of recording patient notes, of recording outcomes that don't communicate with each other. And sometimes we see that a patient can be seen in one location on one day by one profession, and they can come back the same day or the next day and see a different professional at the same location, and the two professions don't have access to each other's notes, which has lots of challenges around that. But you're in a unique position, being a clinician and someone who's living with diabetes, because some of it is about that, or a lot of it's about that coordination of care and that continuity of care, reducing that duplication, because I'm sure as a patient, having to provide the same information to numerous different professions is frustrating, but also it's, there's a real difficulty that we have in terms of providing the most efficient service that we can, but also reducing risk and improving patient safety by everyone having the information accessible to them. So I'd be interested to get your perception from both being a clinician, but also being a patient living with diabetes, or a person living with diabetes, in terms of that ability to coordinate care much better.
Again, I think that will be really good, because as a DSN, more so than a patient living with diabetes, it can be very complicated. As you say, a patient goes to see someone else and then they're having to feed back their story to me, and that can be frustrating with a person that, like, they've just shared that information with someone else. Why are you not talking to each other, and why have you not discussed this? Why do I have to repeat everything, as you said, Peter? So no, it'll definitely help, and it'll help. Even I work mainly in inpatient care as well, so it'll help with staff in the wards and other clinicians to know what my input has been as a DSN for that patient, that all the information is in one place, that you're not having to go to the notes, you're not having to go to ECR, and it's easy to see. And as you said as well, safe for the patients, and it's all about safety for patients as well.
Yeah, that aspect's a huge one for inpatient care. Quite often our records are held in different places, and we're trying to be careful by bringing, recording information in different places so that people can access it, Sharon. But we know that if we don't do that, it can be hard to make sure the message is carried forward. I will say with Encompass, there'll be a single line of information, a continuous narrative from whoever's input it is by time. So you will be able, our records about what we have advised for people living with diabetes in the hospital and other conditions will be much more visible, and our prescribing safety will rocket. At the moment, it's all paper-based, manually written, manually checked, subject to handwriting, and there's large numbers of staff are devoted to quality assuring that. And diabetes is a very good example of that. It's written wrongly. There can be tenfold errors. In fact, to the point that our glucose monitoring and insulin prescription sheets, we have removed the term, it used to be international units, abbreviated to IU, but that could be misinterpreted. A 7 could be IU could be misinterpreted as a 71. And that gives you an idea of the potential risk and how the paper-based systems can go a little bit, but they can't completely, can't reduce that risk. So we're looking forward to that, I have to say, in diabetes care, Sharon. We can see where it will help people.
And like staff, like from a day-to-day aspect of my job, staff are afraid of diabetes. That's one thing, like they say that on a day-to-day basis. So hopefully with this, it'll help empower the staff as well to be able to get a bit more confidence around diabetes management.
Yeah, and I think, the benefit of the system is that it isn't just, and Encompass isn't just about patient records. It's not just about note-taking on one system. It also has all of that additional functionality and the prompts that it has, the ability that it has to improve efficiency and time and speed in terms of the documentation is really, really useful. And I think obviously we'll have a challenge at the initial point where people are transitioning on to Encompass and getting used to Epic and new ways of working. But in the long term, the benefits will be so significant in terms of, especially for inpatient care, because that's probably where most of the changes, that's probably where the biggest change is going to happen from our traditional systems. And we'll see such a huge improvement in efficiency across the system, and we'll be able to use that functionality that Epic has to offer for lots of, like I say, lots of those prompts. And as Neil said, the patient safety around medicines management in particular are so beneficial. And for diabetes especially. And ultimately what we'll have is this Encompass system will improve patient care in the long term, which is really what we're all striving for. But also the ability that the system has for us to use some of the information that's inputted to help us guide and evaluate services and help us really try and determine what's working effectively and efficiently, and we can use that to help improve services moving forwards.
Some aspects, Sharon, you referred to about education. We talked about empowerment and availability of information, and we talked about shared repositories of information. What do you see that a system like Encompass might improve for someone living with diabetes and for the professional?
I suppose getting the right signposting to those education that will help our patients. The internet's a big place, and a lot of patients go on the internet, and especially the newly diagnosed patients, whenever they go on, they see a lot of information that can be very stressful and cause a lot of anxiety to you whenever you're reading stuff that you don't really understand. So it's signposting them to things that will help them along their path to understand their diabetes best as well. So hopefully, and then even with the education material online, it would be great, because understanding is key to managing your diabetes.
There was a question there I got about a challenge in getting people who live with a healthcare condition to enroll for access. We certainly find that in endocrinology and diabetes. Although with the NICR patient portal, endocrinology and diabetes is the biggest user by far, but there's huge variation in different areas of the country. So it's very dependent on the team encouraging people to use it. And I think where people living with diabetes and their clinicians who work with them, help them with their condition over the long term, see the value perhaps. Perhaps it's our team the way the teams are set up, or just their appreciation of what condition we're working with. So I think it will be a challenge to get people to register for NICR. It will continue to be, but encompass it's different. It's offering a lot more in My Care Record, Peter, than is available with the current patient portal. You talked about appointments, but also documents and results, which are a wee bit difficult for us to share in the NICR patient portal, but will be, I think, a lot more seamless in the future with encompass. And there's a lot more to gain by registering for My Care Record.
Yeah, and it comes down to scope, what can be offered. And actually with My Care Record, there's an awful lot of scope and opportunities that can be offered through the record, My Care Record itself. And some of them will be implemented at the go live point. And as with everything, there's always opportunities to develop that further and optimize that further as time goes on. And I think it's trying to understand actually and make sure that we have a process and the My Care Record which works for our patients, I think is important. And it's making sure that we don't provide too much information to start off with and scare people off with what's there, but there's an awful lot of functionality that can be offered through that system, and which is being delivered in other locations globally, and the opportunities really are endless for it, I think. And I mentioned before, really it is about trying to improve that partnership and enable people with living with diabetes or with any condition to actually be much more empowered and enabled to be involved within their care. So there's lots and lots of opportunities for that going forwards. And I think over time, we'll see the development of My Care Record, and it will continue to be enhanced as time goes on. And just looking at one question in the chat around GP records and contacts, the answer is, with our primary care colleagues at this moment in time, no, it won't. Our primary care colleagues will have access to the system and will be able to view it from their side, but they will continue to use their current systems, which are EMIS, Vision and Murloc within primary care in the future. Now that might, obviously everything's subject to change as time goes on, but they will have access to encompass and be able to view systems. And we are communicating and collaborating with our general practice colleagues to make sure that they can access the functionality that they need to, but they will continue with their current medical record systems.
Yeah, I think that's fair to say, although there's an interest certainly in joining up those records, but while they're currently affixed to certain separate providers, it's outside the encompass scope at the moment. But as I said, there's definitely interest in developing in that direction, beyond them being able to access encompass records to a shared approach, which will include primary care information. I mean, it will include all laboratory results that general practitioners have requested through trust laboratories, of course. That's true. And I expect that the situation will be there where referrals will also be viewable. So certain aspects of information that has been requested from a general practice will be available through the Encompass Care Record. I did want to ask something of Sharon. Sharon, I mentioned deliberately the fact that the care record follows a person right the way through their life. And can you describe to us how difficult it is at the moment? Molly's young and she has a health condition, but you help to look after her and to make sure she's okay. How easy or difficult is it for you at the present time?
I suppose I'm in a lucky position because I live with type 1 diabetes and I also am a DSN for the past 6 years. So I have my luck on my side that way. But it's different. Pediatrics is very much like they're excellent. The team's excellent for Molly, so they are. I can't fault them. But it's just trying to get the information and getting hold of all of the information that I want, like our bloods and things, and keeping up to track independently without having to badger the team. I don't want to be annoying in that sense because I do have so much information in my head. So it's definitely different in the sense the independence side maybe doesn't start straight away. I know that can be difficult, but I can't imagine how it'll be as the time goes on. I like that fact that things will be going all move together, because I don't have a clue about my pediatric care whenever I was young, or what went on, or things like that. So I think it's good that frame from going from pediatric to adult for Molly.
Yeah, I do think it'll bring some records which are currently paper only into an electronic format, which then can be accessed. So the potential is for it to dramatically increase the information that's available to parents of young children who are really managing their healthcare conditions.
And technology is ever changing, like, so it's trying to keep up with that as well. So hopefully Encompass will be able to provide a bit of support in the sense, like, as technology does improve or technology does change for our young people living with diabetes, that they'll be able to support that change as it goes, because when you get used to something and then it changes, sometimes that can be hard.
Yeah. There's another question there about the chat function in My Care Record, and how do clinicians feel about the idea of being able to be contacted directly? And number two, so what function will it have? I mean, it's native within the My Care Record and can be turned on or off. And I have to say, of course, clinicians are nervous. And there is something about switching attention, you know, in the middle of the thought of being in the middle of a busy clinic with other people, with your attention focused on them, and there's a number of, you know, messages coming through about someone completely different. So there's a nightmare, you know, scenario of potentially too much information, too much access, making it difficult for any clinician to focus on any one person at any one time. But that just means that they need to view it in different ways and alter workflows. We need to change there's no doubt that this will change the way that we work. There's absolutely no doubt at all. It's not as simple as, you know, information being in little boxes here and there, but the chat function is really an inbox of information that you can choose to attend to whenever you're able to attend to it. So I have to say that it's not by far from you know, an emergency access. You know, dear Sharon, I've lost all my insulin and I put it all in the oven and it's melted. Is not you know what we would expect. But people have legitimate questions, and we have to there are lots of implications in how that clinicians will know that they have enough time, you know, at different times to respond in a timely way, and that needs to be managed and carefully thought out. It's something that may not be turned on for all services but at the one time. Connor Everts from Epic is here as well. Perhaps can color that.
Yeah, but I actually, you Neil, you hit exactly what I was going to add, is that it's not something that we just have on by default for all of the clinics. We actually have to do supporting build to make that available for a specific clinic support pool. So what we've discussed previously is that having specific practices or clinics opting in who want to be a part of that available messaging back and forth with patients. So it's something that we understand that that's a very large change and a new way to interact with the patient population. And it's something we try to be very intentional about implementing. It's not something that we just turn on and say, you know, figure it out, guys. So we totally agree with those sentiments.
Yeah, and we are talking about, you know, at a service level, how you can have if you like, a group inbox, and then we can allocate someone to be able to answer the various queries.
And I think some of that comes down to scope. What we were talking about before, it's about having, you know, a system which works for the service area itself, and actually having that ability to have versatility across the system to meet the needs of the patients who are within it and the staff capability that we have. And I think there's so many opportunities there. The opportunities aren't just about patients contacting, it's also about sharing of information. And when we're looking at diabetes, for instance, for our podiatry colleagues, when we're looking at images being shared across about diabetic foot ulcers and wounds, can be a really useful mechanism that information can be shared, that the clinician can look at and review, and then provide the appropriate feedback back to the patient. I think there's lots and lots of opportunities around that space, and some of it is about, you know, healthcare is changing, and the contactability is required, and that just, you know, changes how people access services in certain ways. We've moved away a lot from, especially the pandemic has sped that up, from patients having to have appointments and see someone face to face to get any information from services, to now being, you know, much more accessible, and really helping people to manage their condition much better.
James Nelson has his hand up for a question.
Yeah, it was just to make a comment, Neil, off the back of what you were saying there, I think about patient messaging to staff. I'm sorry I've arrived too late to the meeting, but just something I heard from medics on other UK Epic sites was that we're going to get those messages one way or the other anyway. And if you use the Epic messaging platform, you've got a well-governance route to get them, to share them out, to have it all recorded, to have the patient chart accessible. And they were very positive in general about messaging, whereas my question had come from quite a nervous place about it. So it's just to let people know there's some positive feedback from other UK clinicians using Epic for direct messaging for patients.
That's really important. A lot clearer than I said it.
I think as a patient, I would like that tool to be able to do that, because then you can write in your questions and go about your merry way during your day at work and stuff. So it's an easier way to access patients rather than having to phone or email. But no, I can understand how it can be scary from a clinician point of view, thinking that you're going to get a whole pile of messages from patients and have to respond to them in a timely manner.
And I think the comment made by James is really, really important. The governance and safety element of it is vital. And that isn't just for information coming to clinicians, it's about the information you're sharing back. And I know for AHPs, as an example, in the pandemic, where we'd moved from a lot of face-to-face consultations to virtual consultations and providing information to patients, having a platform and a mechanism that we know was secure and we know had all of the relevant governance processes in place is really, really important. And I think that just opens this up to having that process in place where we don't have to be concerned about, you know, sharing a website with a patient or getting them to send something through on a specific device to us. It's definitely the governance processes around this have been worked up and mean that we can be confident about the platform that's being used. I'm sorry, Linda, did you want to come in?
Yeah, I just wanted to ask a question. Are we building Encompass to how we do business now, or how we see us doing business in the future? So are all the diabetes clinicians and AHPs that are sort of attached to that agreeing now that we are going to open messaging at some point in the future, and we're looking at our business workflows and our processes and our governance now to facilitate that? Or are we just taking what we do now and saying we're just replacing this with an Epic product?
I think it'll release potential and the ideas. At the present time, I can tell you in diabetes care, people are talking about exactly what James talked about, which is how we can gather the message together so that they're answered in a timely way from within the specialty team. So it's adjusting, automatically adjusting practice based on, is the principle right? Should we be able to have direct communication with the people living with the condition that we're helping? Well, yeah, is the obvious answer. But how then do we work it? So the foundation system's coming with all these tools, and as Connor said, there's an extra build with respect to messaging. But the very foundation system itself, it will almost automatically change the way that services run and operate. And I think the messaging system is a very good example of that. That's very easy to understand and it's very tangible. So in a way, the services just roll on in the same old pattern that they always roll on, whether that's efficient or inefficient. This is a golden opportunity to change the way that services function and help them function in a more efficient way. We can be too focused on, you have to click this box and that box and how long it takes to navigate the system. But once you become fluent with that, the potential for release of more fluid clinical activity that's more focused to what is required at the time is immense. So I think it's unavoidable that there'll be the way services operate will change.
And I think to answer the question as well, I think it's both. I think we're creating a system that will work now, but we've got an eye on the future about how we would like the system to look. And I think when we're looking at currently, we have so much variability with how records our patient notes are recorded, what outcome measures are used, what assessments are used in different areas. And we have a number of different opportunities in the system now, and one of which is to have a degree of standardization regionally across services about how we code data, what information we're looking to add into Epic, what outcome measures we want. And we're thinking about, we know the challenges we have, and we haven't really touched a great deal upon the other benefit of this, which is the extraction of data to evaluate and review services and to support commissioning and how services are delivered and coordinated in the future. But we have to consider all of those elements, because the Epic is about trying to improve the delivery of care, as well as just pulling a number of systems onto one overarching process. So I think we have to look at both, and I think that's part of the opportunity that we have at this moment in time. And I think we'll see a lot more standardization of care, a lot more ability to evaluate services. We'll see a lot more efficiency in the system moving forwards. And I think we'll have really, it's a transformational project, and we'll see a transformation in the way health and social care is delivered moving forwards.
There's another question in there around patient representatives and groups being involved to date in the shaping of how MyChart might operate.
I don't think enough of that has been done, and everybody knows that to date, Damien. But there's an active plan to expand it. I can't give you details personally at the moment.
They're actually Encompass and the guys looking after My Care Record are linking in with the Patient Client Council in September. They've already had some discussions with it. We're actually going actively out now to set up a work stream and a working group to give feedback and to be involved in all the look and feel and development of My Care Record, and then reaching out further to other groupings for the easy read and disability access and all of that sort of thing. So yes, probably ramping up now from September going forward in all that development.
Jill had put a good point in there too in the chat about how we have to include our capacity as staff. Is that, I took that up right, Jill, did I? When it comes to group and chat and stuff as well.
I think it's what Peter has said about changing how we work. So if we're thinking about an episode of care with a service user, part of that episode of care will include the messaging and the responses to those messages. And that's a really important thing that we should do in terms of patient safety and empowering patients. But we have to make sure that we include that in our capacity. And it's not just the clinic face-to-face, either virtual face-to-face time that we're counting up. We're also saying this is part of the whole care package. We may need to include that in our capacity workings out. And the other bit would be around setting the expectations for service users. So yes, you have this facility where you can message us, and the standard is that we will respond within whatever we think is a reasonable standard, that it won't be instant response.
Yeah, I think that's a really, really good point, Jill. And I think Neil touched on it before around, it's about patient expectations, and some of it is in emergency situations or urgent situations. Patients know how to access services which are required for them at that moment in time, and it is about the reconfiguration of how we deliver care. Because actually, if you know, a message system is opened up and clinicians are getting, you know, lots and lots of messages, it will have a significant impact upon their capacity to deliver what would have been the traditional method of delivering care. So it is a changeable process, isn't it? And we've seen a lot of that with COVID and in the pandemic, where there was a lot more virtual consultations, and the method of contacting and delivering care did change, especially in community services and non-acute services. So we do have to factor that in, and we have to consider actually what this will look like in the future, and that will have an impact with our SPPG colleagues and the Commissioner of Services. So certainly I think that's a really valid point, and lots of conversations will have to be had around that moving forwards, I think.
Just on the governance of that, Peter, will clinicians have access to the My Care record and the chat and responses? Because I'm just thinking up from a governance point of view in terms of auditing that information, because otherwise the clinician would then have to record elsewhere that they'd had that communication with the patient. So I think that's in terms of the build. If you're doing a response to a question, can that be part of your patient care record that can be audited?
Yeah, and my understanding is, yes, that is the case. Connor, I see you nodding there. So yeah, that the two systems are interlinked essentially, and they enable that auditing process to take place.
Thank you.
Connor made an interesting point, actually, and something that we mentioned, which was information comes through anyway, one way or another. And sometimes with a traditional system, the only way to deal with that problem is to have a face-to-face or a clinic appointment, whenever a more fluid communication might have done. He mentions that well, it seems like another sector of work for clinical staff. It reduces face-to-face visits when they may have been unnecessary. There's an awful lot of, it can be very revealing how someone asks a question and what they ask. If we can respond to that, then we may deal with a problem. It takes clinical time, but that could replace less efficient time. I think we already see that in diabetes care. There's a lot of unmeasured activity and time, Sharon, from patient contacts that aren't measured by traditional methods.
Yeah, and that's a good thing, I suppose. Peter and Alma talked about like being able to gather data and stuff. We haven't been able to do that as DSNs with the number of phone calls and ad hoc work that we do, whereas hopefully Encompass will help us as clinicians and DSNs support that and be able to gather data.
Yeah, and I think that's a huge component of this, is to be able to extract the data that we need to quantify the efficiency and effectiveness of services, how care is delivered. And I think Epic we've had so many problems with extracting data, and that's a real challenge that we've got across the current systems that we use. And Epic will give us a much more fluid and much more real-time ability to view data as we need to, and that fundamentally will impact upon, you know, how care is delivered, because that information will be used to measure effectiveness of services, but also used to help guide how service should be delivered, and it will, you know, lead to much more evidence-based practice and care, and much more efficient services moving forwards, I think.
Neil, there's a question there from Karen Dolan about being able to upload data to the system. Can you pick that one up, please?
Yeah, so Karen, you mentioned your child has a flash glucose monitor and a smart pen, smart insulin pen. And the hospital staff, our team, use the records in those devices as a basis for chats at the clinic. And presumably this will be uploaded to the new system too. As far as I know, the MyCare record does allow opportunity to upload documents that are downloaded from these apps. I don't know that information from third-party apps is going to be interfaced in, Connor, but it's more that it could be accessed, downloaded, and then uploaded to the MyCare record. Is that right?
Yeah, I'd actually answer this in 3 ways very quickly. Is yes, you can absolutely just upload a scan for a document for a clinician to review. Second is we do allow access for discrete data entry. So let's say just for example that it's a blood pressure or glucose level, you can just input that yourself as a patient, and that's viewable by the clinicians overseeing your care. And then there is actual functionality to integrate with some apps. The biggest ones being like Health Kit for the iOS. I forget what the Android analog is, but some applications like that can integrate directly. And what we often see is that the devices like the Smart Pen will integrate into the iOS platform, which then integrates directly into the MyCare record. At this point, for the initial go live, I think that level of integration is being held off for optimization, which is very common for a new organization that's transitioning over. But those are the different ways for data entry into the MyCare record.
I think this is really welcome for people living with diabetes and those helping look after those who live with diabetes, including parents, as Karen has asked that for a very specific reason. There's huge amounts of information now being gathered, and it's a shame if that can't be integrated together. So Connor's, I think that's really encouraging, Connor, that the MyCare record can be used to share data like this.
I have another question around prompts for patients for preparation for clinics. Another useful tool, I'm sure all our clinical friends would agree.
With 5 minutes, I'll just say yes is the short answer to that question.
Okay.
Yeah, it's something that we do a lot in diabetes care, Sharon. The discussion's always much more productive if the information has been gathered before. And if that information has been gathered before, whether it's glucose data, laboratory data, and it's been shared, then both the person with the condition and the clinician can reflect on it before and after. So we can see a potential totally different dynamic with what Connor's just, the yes that Connor's given us, along with messaging. You can see a lot of empowered work going on around a clinic appointment.
Definitely beneficial.
It's a much more concise answer.
I am very conscious that we're in our last few minutes of the session. So are there any final questions that you want to put up in chat? And if need be, I can have them sent on and we can send them back to individuals. That's okay. As always, a very interactive session whenever we come to talk about Encompass, which shows that people are obviously getting to grips with what's coming down the track. So thank you very much to Peter, Neil and Sharon for taking the time out on a Friday afternoon to field the questions and give us some of their personal insights. If you do have any questions about what's going on in your trust area by way of preparation, contact your Encompass EPMO or look up on your trust website. There's regular updates from Encompass. One's just gone out this week, and they're letting you know about work that's going on at the minute. So there's some tasks getting ready right across all the organisation, role analysis and device assessment that will help make this programme a success. So I would encourage you all to engage with that if you're asked to participate. It's all about making sure that people are trained to be able to use the system and to have the right devices to be able to access it as soon as it goes live in your area. So once again, thanks very much, and I hope to see you all again on the 7th of October for our next digital dispatches.
Thank you.
Thanks, guys. Thank you.